Welcome to the GMJ Podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy.
This episode reviews the article titled, Patient-Centered Care in Liver Transplantation in Georgia. Implications for Professionalism, Communication, and Accredited Transplant Services.
So let's start off with a bit of a visualization for you, the listener, because when most people think of a liver transplant, the mind immediately goes straight to the operating theater.
Right, the surgery itself.
Exactly. You picture the bright lights, the monitors beeping, the technical audacity of taking a vital organ from one human body and just plumbing it into another.
It really is something out of science fiction when you step back and look at it.
It is. It's arguably the peak of surgical intervention.
A Mount Everest of medicine, right? It's certainly viewed that way by a lot of people. It's high drama, it's high stakes, and obviously it's incredibly complex.
Yeah.
But, the article we are examining in this deep dive argues that this technical fixation...
The obsession with the heroic surgery part.
Yeah, exactly. This obsession with the surgery is actually, it's a significant blind spot.
A blind spot. That's a pretty bold claim for a procedure that literally saves lives on the table.
It is a bold claim. But consider this. If we focus entirely on the mechanics of the surgery, we completely miss the actual ecosystem required to keep that patient alive for the next 20, maybe 30 years.
Right.
The surgery takes maybe 12 hours. But the patient care, that takes a lifetime.
And that is really the core of our discussion for you today. We are reviewing a really fascinating commentary by Sulkhan Inaishvili from Avicenna Batumi Medical University.
Yes.
And the title focuses on this concept of patient-centered care, which, I'll be honest, sometimes sounds a bit like a buzzword to me.
Oh, absolutely.
Like, something you just slap on a hospital brochure to make people feel all warm and fuzzy.
It is very often used exactly that way in marketing, unfortunately.
Yeah.
But Inaishvili is arguing that in the specific context of liver transplantation in Georgia, patient-centered care isn't just about, being polite.
Yeah.
It is a structural survival mechanism. Literally, without it, the surgery fails.
So the thesis of the paper isn't just, be nicer to patients. It's more like change the system or lose the organ.
Precisely. The central research question here is, as Georgia expands its liver transplant services, which has been a major goal over the last decade or so.
Right, they've been ramping that up.
They have. So how do we ensure the system keeps up with the surgeons? The author argues that patient-centered care, or PCC, it must be redefined, not as a soft skill, but as a hardcore organizational and educational responsibility.
Okay, so it requires an integrated system of professionalism, communication, and institutional accountability.
Exactly. It's about building a competent system, not just having a nice doctor.
Right. I really want to dig into that because it sounds like a massive shift in mindset. But first, let's make sure we understand the landscape. Why is liver transplantation so unique?
That's a great question.
Why does it need this systemic armor more than, say, an appendix removal or a knee replacement?
Well, there are a few unique pressures here that the text really highlights. The first one is obvious: organ scarcity.
Right. There are never enough organs.
Exactly. Unlike a knee replacement, where we can just manufacture the titanium part in a factory, a liver must come from another human being. Demand always outstrips supply.
Yeah.
But the second factor, and this is absolutely crucial for the context in Georgia and frankly many other regions, is the heavy reliance on living donor liver transplantation.
Right. Okay. So this is where a completely healthy family member donates part of their own liver.
That's the one. And just pause for a moment to consider the ethics of that.
Yeah, it's intense.
The fundamental medical dictum is primum non nocere. First, do no harm. But in a living donor situation, we're taking a perfectly healthy person, subjecting them to a major life-threatening surgery, inflicting pain and recovery time.
Solely for the benefit of someone else.
Yes.
When you frame it that way, it almost sounds contrary to the basic oath of a doctor. You are intentionally harming a healthy person to save a sick one.
It walks a very, very fine ethical line. And this is exactly where the system comes in. Because if you have a surgeon who is just a technical wizard, well, that's great for the cutting.
Right.
But who is checking the coercion, who is ensuring the donor is safe psychologically.
Wait, coercion, you mean like pressure on the donor from their family?
Imagine a family dynamic. Say a father needs a liver.
Yeah.
The son is a match. Does the son actually want to donate? Or does the entire extended family just expect him to?
Oh, wow. Yeah.
If the hospital doesn't have a rigorous, independent psychological assessment process, a system to protect that donor, the surgery might be a technical success, but it's an ethical failure.
That is a terrifying thought, honestly. So the patient-centered care here isn't just for the sick patient, it's for the silent patient, the donor.
Exactly.
And the text also mentions prolonged care pathways, so this isn't a fix-it-and-forget-it kind of situation.
No, not at all. It's a lifelong marriage between the patient and the medical system. And this brings us right to the context in Georgia.
Okay.
The article notes that while transplant services have indeed expanded, this rapid growth has exposed some pretty deep systemic cracks.
What kind of cracks are we talking about?
We are seeing challenges in access, continuity of care, and especially ethical governance. It is essentially like building a high-performance Formula One engine, which is the surgery, but putting it in a car with a rusty chassis and bad brakes.
You might go incredibly fast for a mile, but you're going to crash eventually.
That is a very apt analogy.
And the crash, in this case, often happens long after the patient goes home. Which brings us to the core findings and the analytical argument of this paper. What actually happens when that chassis, the system, isn't aligned with the engine?
The article points to a very specific and highly dangerous outcome: non-adherence to immunosuppressive therapy.
Okay, let's unpack that for you. After a transplant, a patient has to take powerful medication to stop their body from rejecting the new liver, right?
Correct.
We generally assume that if a patient doesn't take their meds, it's their own fault, like they were forgetful or careless or whatever.
That is the common assumption, yes. But the analysis here flips that script completely. The author notes that adherence isn't just about willpower. It is heavily, heavily influenced by communication.
How so?
If a patient doesn't understand why they are taking the meds, or if they feel totally disconnected from the care team, they stop taking them.
But why would someone stop taking a pill that literally saves their life?
Because the side effects are brutal. We're talking tremors, nausea, severe hair loss, constant risk of infection.
Oh, wow.
If you don't trust your doctor, or if you feel like you're just being treated as a number on a chart, the motivation to endure those side effects just evaporates.
That makes total sense.
The article actually cites a review on risk factors for non-adherence, and it notes that the quality of the relationship with a healthcare provider is a major determinant.
And this connects perfectly to a concept the author brings up called the hidden curriculum. I found this term absolutely captivating when I was reading the source.
It's a great concept.
It sounds like something out of a spy novel or a thriller, but it's actually about medical education. Can you explain what the hidden curriculum is?
It is one of the most pervasive forces in medical training anywhere in the world. Think about it this way. You are a first-year medical student. You sit in a lecture hall, and the professor tells you, always listen to the patient's concerns about their medication. Empathy is key.
Okay, standard textbook advice. Everyone nods, takes their notes.
Right. But then, 2 hours later, you are on clinical rounds. You're shadowing the chief of surgery. Your absolute hero, the person whose recommendation letter is going to determine your entire career.
The stakes are high.
Exactly. They walk into a patient's room. The patient starts to ask a very genuine question about side effects. The chief takes his watch, cuts the patient off, says, "It's fine, just take the pills," and walks right out.
Oh, I see. So the student learns that the lecture was just theory, but this, checking the watch, this is reality.
Correct. They learn that professionalism is optional and that speed and volume are the real currencies of success. That is the hidden curriculum.
It's what you learn by watching, not by reading.
Exactly. And Inaishvili argues that in liver transplant programs, this hidden curriculum is deadly.
Because even if the textbook says, listen to your patient, if the professor is checking their watch and rolling their eyes, the student literally learns to check their watch and roll their eyes.
Yes, and that behavior trickles down through the whole system. If the next generation of doctors learns that technical speed is the only thing that matters, we will continue to see these massive gaps in communication.
And as we just discussed, if communication fails, adherence fails.
Right.
And if adherence fails, the organ is rejected.
Precisely. That is the causal chain the author is drawing. It links the micro-level interaction, the doctor talking to the patient, all the way up to the macro-level structure of medical education.
It's chilling when you trace it out like that. That quick glance at the watch by the senior doctor could essentially cost the patient the organ 3 years down the line.
That is the argument, yes.
Now, let's talk about the evidence here. Because this is a commentary piece, so it's fundamentally an argument, but it obviously needs to be backed up. How did the author arrive at these specific conclusions?
The author synthesizes three distinct types of evidence to build this case. First, there is international evidence. They draw on data from the OPTN, which is the Organ Procurement and Transplantation Network, and the NHS blood and transplant reports out of the UK.
So they are looking closely at the really big global players to set a baseline.
Correct. This provides the global benchmark for what good actually looks like. Second, they utilize Georgian clinical experience directly.
Bringing it back home.
Yes. They reference local reports, like the Georgian Association of Transplantologists activity reports, and specific studies on early outcomes and blood groups in Georgia. This really grounds the theoretical argument in the local practical reality.
Right, showing what's actually happening on the ground. And the third type of evidence.
The third is accreditation standards. The article specifically references Accreditation Canada's Cumentum Global Standards regarding organ donation.
I noticed that. It's super interesting that they are referencing Canadian standards in a uniquely Georgian context. It suggests a really strong desire to align with the absolute highest global bars.
It does. It shows that this isn't just about reinventing the wheel locally. It's about adopting frameworks that have been proven to work elsewhere.
Right.
The author is benchmarking Georgia against standards like the Declaration of Helsinki and World Health Organization guidelines. It's a very clear call to professionalize the entire ecosystem.
Okay, so let's move toward the solution side of things. We have the problem clearly laid out. Systemic gaps lead to poor outcomes. And we have the evidence. What actually needs to change? What are the institutional and policy implications we are looking at?
The focus shifts heavily to that third pillar, accreditation. The article lists specific areas that need rigorous, standardized oversight.
Okay, I have to play devil's advocate here for a second. To the average listener, accreditation just sounds like a whole lot of bureaucracy.
It often does, yeah.
It sounds like endless committee meetings, checklists, and piles of paperwork. Does it actually change patient care at the bedside, or is it just red tape?
It's a very fair skepticism.
Yeah.
But think of accreditation not as paperwork, but as standard operating procedure. Without it, excellence in a hospital is accidental.
Accidental?
Yes, it depends entirely on whether you happen to get the good doctor on a good day. With accreditation, excellence becomes systemic. It's mandated.
Can you give me a concrete example from the text to illustrate that?
Sure. Let's look at the access and intake standard that's mentioned. Without accreditation, who gets the next available liver? Maybe it's the person who happens to know the hospital director. Maybe it's the person with the most money.
Ah, I see. So it actively prevents corruption and bias?
It mandates total transparency. If you want the accreditation stamp, which, by the way, you need for international recognition and ongoing funding, you must prove that your waiting list is managed by a strict algorithm based on medical urgency, not by a handshake in a back room.
That makes total sense. And what about that living donor issue we touched on earlier? Does accreditation help there?
Absolutely. Accreditation requires strict independent oversight to prevent coercion. We have to be absolutely sure that the donor is giving the organ freely, without any unethical incentives.
What counts as an unethical incentive?
The text clearly distinguishes between ethical incentives, like, say, removing barriers to donation by covering travel costs or lost wages, versus outright payment.
Right, buying an organ.
Exactly, which is ethically unacceptable globally. Accreditation effectively acts as a shield for the vulnerable donor.
Yes, it protects them from both family pressure and financial exploitation.
The author implies that without these accredited structures, professionalism is just left up to luck. With them, it becomes a guarantee. And that leads directly to the key insight of the article regarding integrated systems.
Tell me more about that.
You simply cannot have a world-class transplant unit functioning inside a dysfunctional hospital ecosystem.
Right, because the transplant unit is totally dependent on the pathology lab, the nursing staff, the administrative intake team, the ethics committee. They're all connected.
Exactly. If those surrounding systems aren't up to the exact same standard as the lead surgeon, the patient falls through the cracks. The author states we need a fundamental shift. We need to move from volume to value.
Let's zoom out to that system-level reflection for a minute. Volume to value. That sounds a bit like business school talk. What does that actually mean for a patient sitting in a clinic in Batumi or Tbilisi?
For a long time, the primary metric of success in developing transplant programs might have simply been, how many transplants did we do this year?
Right, a volume metric. It looks great on a bar graph.
It does. It shows rapid growth and capacity. But value asks fundamentally different questions. It asks, how is the quality of life for those patients 5 years later? Did the living donors regret their decision? Did the families feel supported throughout the process?
It's a much deeper look at the impact.
The text strongly suggests we need to transition from simply increasing the sheer number of surgeries to drastically improving the quality of the entire lifelong experience.
And this touches on the concept of ethical governance that's mentioned toward the end of the text.
Yes, the author posits that patient-centered care is actually the only way to sustain the transplant program in the long run. Think about it. If the public loses trust because of a scandal, or because of poor communication, or ethical lapses regarding living donors, what happens?
The donor pool dries up, people just stop volunteering entirely.
And the program fails. Full stop. So these soft skills, communication, empathy, rigorous ethical oversight, they are actually the concrete foundation that holds the entire system up.
Because without them, the technical capacity is meaningless. You won't have the public trust required to even operate.
That is the perfect way to frame it. The goal described here is a system where education, which is teaching the doctors, governance, which is making the rules, and accreditation, which is checking the rules, all align perfectly to protect the vulnerable patient.
It's really fascinating. We usually think of hard skills as the surgery itself, and soft skills as just the bedside manner. But in this framing, the soft skills are the structural integrity of the entire building.
Exactly. The scalpel is just the entry point. The author, Inaishvili, is effectively saying that Georgia has successfully built the engine. The surgical capability is undoubtedly there. Now, they must aggressively build the chassis.
And that chassis is built out of ethics, accredited standards, and the careful way a medical student is taught to speak to a frightened patient.
It is entirely about closing the gap between what medicine can do technically and what medicine should do ethically.
So as we wrap up this deep dive, here's my final thought for you, the listener, to take away and mull over. We so often celebrate the medical breakthrough, right? Like the first time a complex surgery is performed.
Always a big headline.
Always. But maybe we should be celebrating the systemic breakthrough just as much. The day a hospital creates a communication protocol that ensures a donor isn't coerced, or a patient is truly heard and understands their medication, it's way less glamorous than a 12-hour surgery, but ultimately it might save far more lives over the long term.
I couldn't agree more. The system is the true safety net. And as this article so powerfully argues, for liver transplantation in Georgia, that net needs to be woven very, very tightly.
Thank you for listening to the GMJ Podcast.
For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description.
We look forward to continuing these scholarly discussions in future episodes.